Welcome to the Hospital Medicine Unplugged podcast.
It's great to be here.
Today, we are conducting a really rigorous analysis of the clinical management and metabolism of the fat-soluble vitamins. That's A, D, E, and K.
Right.
We're taking a subject that I think for many of us is often relegated to the back of our minds, and it's maybe something we memorized for step one and then, largely automated in our daily practice.
And we're bringing it right into the acute care setting.
Exactly.
It is so necessary to revisit this. The landscape of nutritional science has really shifted significantly, I'd say, in the last decade.
In what way?
Well, we're moving beyond just a basic understanding of, classic deficiency syndromes. We're getting into a much more nuanced territory.
Okay.
We're talking about complex absorption mechanisms, competitive interactions between the vitamins, and toxicity risks that are surprisingly relevant in the hospital setting.
So the goal for this deep dive is really to push past that basic nutritional knowledge.
It has to be.
We want to equip you, the clinician, with some evidence-based enhancements to standard practice. We aren't just talking about telling patients to, improve their diet.
No, this is much deeper. We're looking at membrane transporters, how these vitamins actually fight each other for absorption.
And the specific, often missed clinical manifestations. Things like neuroophthalmologic issues and some of those subtle coagulation defects.
And this is just so crucial because our patient population is changing. Think about it. We see more malabsorptive procedures, more bariatric surgeries.
More complex pharmacotherapy.
Exactly. And an aging population with multi-morbidity. Understanding the physiology of absorption is really the first, most fundamental step in managing these patients effectively.
So let's unpack that physiology first. I think for a long time, the prevailing dogma was that fat-soluble vitamin absorption was a relatively simple passive process.
That's right.
The assumption was just that you eat the fat, the vitamin dissolves in it, and then it diffuses across the gut wall. Simple as that.
That is the classic teaching, passive diffusion. The idea was that if you have adequate bile salts and, pancreatic enzymes to form the cells, these lipophilic molecules would simply drift across the enterocyte membrane, just following a concentration gradient.
But that's not the whole story.
Not even close. Recent research has effectively dismantled that passive diffusion myth. It turns out the gut lining is far more selective and, frankly, far more regulated than we previously believed.
So it's not just an open door.
No.
It's more like a checkpoint.
It's precisely a checkpoint. We have now identified specific membrane transporters that are critical for the uptake of vitamins D, E, and K.
So this isn't just random movement.
No, this is a facilitated process. We're talking about proteins like SRBI, which stands for scavenger receptor class B type I.
And CD36 is another one, right? A major player in this space.
Yes, CD36 and also MPC1L1, that's Niemann-Pick C1-like one, and then there's ABCA1.
Now, some of those names, especially NPC1L1, should sound pretty familiar to anyone who treats hyperlipidemia.
They should. A cardiologist or a lipidologist would recognize them because these are proteins we often discuss in the context of cholesterol transport.
So they're doing double duty.
They are. They're basically hijacking, or, a better word is facilitating, the entry of these vitamins. For instance, NPC1L1 is the specific target of the drug ZMA.
Which raises a really significant pharmacological question then.
It does.
If we're using a ZMA to block cholesterol absorption by inhibiting NPC1L1, are we at the same time inadvertently inhibiting the uptake of vitamin D or E or K?
Theoretically, yes. The potential is absolutely there. When we modulate cholesterol absorption with a drug like that, we might be affecting vitamin uptake as well.
It implies a level of drug-nutrient interaction that isn't typically, flashing on the medication reconciliation warning list.
Not at all. It's much more subtle.
Okay, so we have these specific, let's call them taxi drivers, for vitamins D, E, and K. What about vitamin A? Where does it fit into this new model?
And that is where the physiology diverges. It's the interesting part. Despite identifying transporters for the others, no specific membrane proteins have been definitively identified for dietary vitamin A uptake.
So it's the outlier.
It remains the outlier in this group, yeah.
Yeah.
It seemingly relies more on that classic passive model, or perhaps, transporters that we just haven't characterized yet. Science is always evolving.
This discovery of transporters, it completely changes how we should view bioavailability.
It has to.
It implies that there's a saturation point. If you have a finite number of transporters, you can overwhelm the system.
It implies saturation, and I think more importantly, it implies competition.
Right.
If you have a limited number of transporters, let's say for SRBI, and you flood the system with multiple fat-soluble vitamins at the exact same time.
They're all going to be fighting for the same seat on the bus.
That's a perfect analogy. They're going to compete for access. And we see this. We see competitive interactions where vitamins D, E, and K are all competing for these same uptake mechanisms.
And vitamin A plays a unique role in this competitive landscape as well, doesn't it?
It does. It plays a very unique role. The data suggests that vitamin A actually decreases the uptake of the other fat-soluble vitamins.
So it inhibits their absorption?
Yes. But here's the twist. Because it doesn't seem to rely on those same transporters, it is not affected by them.
Wait, so let me get this straight. In the competitive environment of the gut lumen, vitamin A is the dominant force.
That's right.
It pushes the others out of the way, but the others can't push back.
You've got it. It's a one-way interaction.
Wow, okay, that has immediate clinical implications when we think about how we supplement our patients.
Absolutely.
We often order a multivitamin formulation, or, the supplements are administered simultaneously in a single med pass.
We do, and we should probably question that practice, at least in our high-risk patients. Consider the bioavailability of a standard multivitamin formulation.
If you have high doses of vitamin A right alongside D, E, and K,
you might be actively dampening the absorption of the latter three. It raises a really practical question of whether we should be staggering administration in patients with critical deficiencies.
So, giving vitamin A at a different time of day than vitamin D or K.
Exactly. Rather than bundling them all together, it's a level of nuance that is completely lost in our standard one-tab daily orders.
Okay, that's a fantastic point. Let's move from absorption to the specific agents themselves. Let's analyze vitamin A. We touched on its absorption dominance, but let's examine its clinical footprint. Vision, immunity, and, of course, toxicity.
Right. We all know the classic association with vision. That's medical school 101.
Yeah.
But I think we need to really understand the progression of the pathology. It's not like it just starts with blindness.
Okay, so what's the first sign?
The very first manifestation is night blindness. The patient might complain of, difficulty navigating the house after the lights go out, or maybe trouble driving at dusk.
And this is so often dismissed, especially in the elderly population, as just a normal part of aging. But structurally, what's happening in the eye?
From there, it progresses to xerophthalmia. That's a distinct dryness of the conjunctiva and cornea, and it's due to squamous metaplasia.
And then you start to see physical signs.
Yes, then we see Patas spots. If you look at the eye, you'll see these superficial kind of foamy patches on the conjunctiva. What you're actually seeing is keratin buildup.
And this is a critical juncture.
It is. If we intervene here, we can save their sight. If we don't, it progresses to corneal ulceration, keratomalacia, and eventually irreversible blindness.
And I think it's really dangerous for us to assume this is only a problem in, low-resource settings.
That is such a critical point for the hospitalist. We see this in high-income countries. We see it in children or adults with highly restrictive dietary habits.
What we might call selective eating or even AR-FID.
Avoidant restrictive food intake disorder, exactly. A patient who, for whatever reason, only eats French fries and white bread for years can absolutely present with permanent ocular sequelae from vitamin A deficiency.
That's frightening.
We have case reports of blindness in developed nations purely due to diet. It happens.
Beyond the eyes, we also have to look at the systemic effects. Vitamin A is crucial for epithelial integrity, isn't it?
It is. It alters epithelial keratinization throughout the body, not just in the eye. But perhaps more acutely for the hospitalist is the effect on immunity.
How so?
Vitamin A deficiency directly impairs T-cell immune function. So what that means is these patients have a significantly increased susceptibility to infections.
So in a complex inpatient with, say, unexplained recurrent infections and a poor nutritional history,
vitamin A status should absolutely be on your differential diagnosis.
Now, on the flip side of deficiency is toxicity. And vitamin A is one where toxicity is a very real, very dangerous possibility.
It is. We have to be extremely careful with hypervitaminosis A. The central nervous system findings are particularly alarmist. It presents with elevated intracranial pressure.
We're talking about the pseudotumor cerebri picture.
Exactly. Severe headache, vomiting, and crucially, papilledema.
Papilledema is a key finding there, a real red flag. And in infants, how does it present?
In infants, you'll see bulging fontanelles. It can look exactly like meningitis or hydrocephalus. It's a neurologic emergency.
What about outside the CNS? What else should we be looking for?
Hepatotoxicity is a major concern. It can cause liver injury that mimics a whole host of other pathologies.
Okay.
And interestingly, bone abnormalities. Vitamin A toxicity can lead to bone pain and an increased fracture risk
Why is that?
because it actually antagonizes the vitamin D receptor. So high levels of vitamin A functionally block vitamin D activity right at the receptor level. It's another one of these complex interactions.
And we absolutely cannot forget the teratogenic effects.
Absolutely not. It is highly terogenic. This is why we're so cautious with retinoids in dermatology. But systemic toxicity from over-the-counter supplementation carries the exact same risk.
So what kind of dosing gets you into this kind of trouble? Is this easy to do?
Well, chronic toxicity in adults generally requires pretty substantial dosing. We're talking about 50,000 international units daily for more than 18 months.
So it takes a while, but it's not impossible.
Not at all. It's not impossible to achieve if a patient is self-supplementing aggressively or if there's, a misunderstanding in a prescription.
So if we suspect this, either deficiency or toxicity, how are we assessing it? What do we order?
Serum retinol is the standard test. Normal is about 1 to 3 micromoles per liter, but we also want to look at retinol binding protein, or RBP.
And what's the cutoff for RBP?
If RBP is less than 0.48 millimoles per liter, that indicates a severe deficiency.
But there's a huge caveat here during stress or inflammation, isn't there? This seems vital for the inpatient setting.
There is always a caveat in the acute phase response, right?
Always.
Retinol binding protein is a negative acute phase reactant. So in a septic or inflamed patient, RBP drops naturally as the liver shifts production to other proteins like C-reactive protein.
So in that context, measuring serum retinol alone or RBP alone can be really misleading.
Completely misleading. It will appear low even if the patient's nutritional stores are perfectly adequate.
So what's the clinical pearl? How do we get around this?
A great pearl here is to use the RBP to transthyretin ratio. Transthyretin, or prealbumin as many of us know it, also drops during inflammation. So by using the ratio, you can help to distinguish a true nutritional deficiency from the metabolic effects of the inflammatory state.
That's a great tip. Okay, let's shift gears now to vitamin D. This is probably the one we ordered the most labs for. It's often called the hormone of homeostasis.
And rightfully so. It really functions much more like a steroid hormone than a typical vitamin. The metabolic pathway is this elegant journey through 3 different organ systems.
It starts in the skin.
Right, it starts in the skin, where UVB radiation from the sun converts 7-dehydrocholesterol into vitamin D3.
And then it heads to the liver.
Correct. The liver then converts it to 25-hydroxyvitamin D. This is the major circulating form, and importantly, this is what we measure in the lab when we order a vitamin D level.
But it's not active yet.
Not biologically active yet, no. It has to go to the kidney for that final critical activation step to become calcitriol, the active hormone.
And that renal step is very tightly regulated.
It's extremely tightly regulated. It involves these intricate feedback loops with parathyroid hormone, or PTH, all designed to maintain calcium and phosphorus homeostasis.
So if calcium drops...
If calcium drops, PTH rises, which then stimulates the kidney to make more active vitamin D, and that active vitamin D goes to the gut and increases your absorption of calcium. It's a beautiful system.
It is a beautiful system, but it seems to be failing on a global scale.
It is, unfortunately, an epidemic. We're talking about over 1 billion people worldwide with some level of vitamin D deficiency. It's staggering.
The consequences are, I think, well known regarding the skeleton rickets in children, osteomalacia, and osteoporosis in adults. But I want to highlight the muscular consequences, which I think get less attention.
This is so often overlooked. Vitamin D deficiency causes a proximal myopathy, a weakness in the proximal muscles.
And in the elderly hospital patient, this translates directly to
an increased risk of falls and fractures. It is not just that the bones are brittle, it's that the muscles are too weak to support them and prevent the fall in the first place.
So treating the deficiency is a fall prevention strategy.
Absolutely. It's one of the few interventions that is proven to reduce fall risk.
Then there is the massive topic of extraskeletal associations. The vitamin D receptor it's ubiquitous, isn't it?
It is in almost every tissue in the body. And deficiency has been linked epidemiologically to cardiovascular disease, type 1 diabetes, multiple sclerosis, various cancers. The list goes on.
The associations are strong.
The epidemiological data is very strong. However, and this is a very big however, the randomized controlled trial evidence for the benefits of supplementation in these extraskeletal conditions remains, frankly, mixed.
So we haven't definitively proven that giving vitamin D prevents a heart attack.
Exactly. Even if low vitamin D is strongly associated with having one, causation is still being worked out.
That brings us to the very heated debate on target levels. What should we actually be aiming for when we get that lab value back?
There is significant debate here. The Institute of Medicine has more conservative targets, which are primarily focused on bone health. But many experts and organizations like the Endocrine Society suggest that for optimal health and disease prevention, we should be maintaining serum 25-hydroxyvitamin D concentrations above 40 to 50 nanograms per milliliter.
And that's roughly 100 to 125 nanomoles per liter.
Correct.
And to get there, for most people, it's not as simple as taking a standard multivitamin.
No. To get to those levels often requires dosages substantially higher than the current government recommendations of, say, 600 or 800 units a day. Many of our patients need thousands of units daily to maintain those levels.
Especially given the prevalence of obesity.
That's a crucial point.
Yeah.
Since vitamin D is fat-soluble, it gets sequestered in adipose tissue. This means obese patients often require 2 to 3 times the dose of a lean patient to achieve the exact same serum levels.
Is there a risk of toxicity with vitamin D? We talked about it with it.
There is, but it's rare. It's much less common than with vitamin A. It usually happens with massive, massive dosing. We're talking hundreds of thousands of units.
What does it cause?
It causes hypercalcemia, hypercalciuria, and can lead to things like kidney stones or calcification of soft tissues. But compared to vitamin A, vitamin D has a much, much wider therapeutic window.
Okay, good to know. Let's move to vitamin E. I feel like this is the great neurologic mimic. We don't often test for it, but the symptoms are so distinct when you see them.
Vitamin D deficiency is a great masquerader. That's a perfect way to put it. It presents predominantly with neurologic symptoms that mimic a posterior column syndrome.
So paint a picture for us. What does that look like at the bedside?
At the bedside, you're seeing peripheral neuropathy, you're seeing cerebellar ataxia and sensory ataxia. The patient will have a positive Romberg sign.
And reflexes.
Reflexia is a very, very common finding, the loss of deep tendon reflexes. You can also see specific things like limitations in upward gaze.
And in severe, prolonged cases.
In severe, prolonged cases, it can unfortunately lead to complete blindness and dementia.
It sounds a lot like B12 deficiency, or even something like Tabes dorsalis.
It does, which is precisely why it's so often missed. The classic syndrome involves a posterior column and a sensory neuronopathy.
Any other clues? Maybe on routine labs?
Hematologically, yes. If you look at a peripheral blood smear, you might see red blood cell acanthocytosis.
So spurred red cells.
Exactly.
Yeah.
That can be a helpful clue pointing you in the right direction.
Now, there is a specific and very important diagnostic trap with vitamin E that I want to highlight, particularly for our patients with liver disease.
This is a critical, must-know point for any hospitalist.
Yeah.
Vitamin E is transported in lipids, in lipoproteins.
Okay.
In patients with cholestasis, you often have significant hyperlipidemia. Because vitamin E just rides along with the lipids, the absolute serum level of vitamin E might appear normal or even high.
Simply because the total lipid pool is expanded.
Exactly. So the lab report comes back, it says normal, but the patient is actually profoundly deficient in their tissues. The absolute number is lying to you.
So what's the solution? How do we avoid this trap?
In cholestatic patients, or really anyone with significant hyperlipidemia, you must use the ratio of vitamin E to total lipids. You cannot use the absolute level.
And what are the cutoffs we should be using for that ratio?
For children, ages 1 to 12, a ratio of less than 0.6 milligrams per gram indicates deficiency. For older children and adults, the cutoff is a bit higher, less than 0.8 milligrams per gram.
So you have to do the calculation.
You have to calculate the ratio, otherwise you'll miss the diagnosis. Full stop.
What about toxicity? Is vitamin E dangerous in high doses?
The primary risk, and this is well established, is bleeding.
How does that happen?
Vitamin E can antagonize vitamin K function. So, particularly if a patient is on anticoagulants like warfarin, high-dose vitamin E can increase the INR and significantly increase their bleeding risk.
And I remember there was a lot of hope for vitamin E in cardiovascular protection a few decades ago. Where did that land?
There was a lot of excitement. The HOPE trial and other large trials looked at high-dose supplementation for cardiovascular prevention. Unfortunately, the results have been mixed at best or, frankly, negative.
No benefit?
No clear benefit.
Yeah.
And some data even suggested a slight increase in all-cause mortality with very high doses. So the takeaway is we supplement for deficiency, but we don't recommend mega doses for general heart health anymore.
Okay, moving on to our final vitamin, vitamin K. This is the coagulation vitamin, of course, but as we're about to discuss, it's about much more than just clotting.
Absolutely. Vitamin K is the essential cofactor for the enzyme gamma-glutamyl carboxylase.
And what does that enzyme do?
This enzyme facilitates a process called gamma carboxylation, which is what activates specific proteins. We all know the clotting factors,
Yeah.
2, 7, IX, and X.
And it also activates the anticoagulant proteins as well.
Right, protein C and S. So it's not just pro-clotting, it helps balance the system. Deficiency results in functional deficiencies of all these proteins.
And at what point do patients start to bleed?
Bleeding symptoms typically appear when the activity levels of these factors fall below about 30%, or 30 units per deciliter.
Vitamin K deficiency bleeding, or VKDB, is a major concern in neonates. It's something we work hard to prevent.
It is, and it's categorized by timing. So,
Ew.
early VKDB occurs in the first 24 hours of life.
And what's the cause there?
This is almost always associated with maternal medications that interfere with vitamin K. Things like certain anticonvulsants, carbamazepine, phenytoin, or anticoagulants like warfarin crossing the placenta.
Then you have classic VKDB.
Classic occurs between days 2 and 7. This is related to low transmission of vitamin K in breast milk and the fact that the newborn gut is sterile and hasn't started synthesizing its own vitamin K yet.
But the one that really scares pediatricians and all of us is late VKDB.
Late VKDB, which occurs between 1 and 3 months of age, is by far the most dangerous form.
How does it present?
More than 50% of these infants present with an intracranial hemorrhage. This is a catastrophic, life-altering event.
And it is almost entirely preventable.
Almost entirely. A single intramuscular injection of vitamin K prophylaxis at birth prevents almost all cases of late VKDB. It is a non-negotiable standard of care for a very good reason.
Now, beyond coagulation, you mentioned vitamin K has other important roles. We touched on calcification earlier.
This is a really exciting, emerging area of intense interest. Vitamin K is responsible for the carboxylation of a protein called matrix glycoprotein, or MGP.
And MGP does what?
MGP is one of the most powerful inhibitors of vascular calcification that we know of. If you don't have enough vitamin K, you can't activate MGP, and your blood vessels may be much more prone to calcify.
And what about in the bone?
In the bone, there's osteocalcin. It's critical for bone metabolism, and it also requires vitamin K-dependent carboxylation to function properly.
So let me see if I have this right. Vitamin K is essential for keeping calcium in the bones where it belongs.
And out of the arteries where it doesn't. That's a perfect summary.
So how do we assess vitamin K status? I think most of us, myself included, just look at the PT-INR.
And that's a real problem. The prothrombin time, or PT, it lacks both sensitivity and specificity for true vitamin K status.
Why is that?
The PT only starts to elongate when you have a very significant reduction in clotting factors, usually when their activity is less than 50%. You can be subclinically deficient long before the PT ever moves.
So what is the better test? What should we be ordering?
We need to be using functional labs. The gold standard here is a test called PIVKA2.
PIVKA2. Okay, let's break that down. What does that stand for?
It stands for protein induced by vitamin K absence, or antagonist 2.
That's a mouthful.
It is. But essentially what it's measuring is undercarboxylated prothrombin. If you don't have enough vitamin K, your body still makes prothrombin, but it can't activate it. So it pumps out this inactive, undercarboxylated protein.
So measuring PIVKA2 gives you a functional assessment of the vitamin status, not just a serum level.
Precisely. It tells you if the body has enough K to do its job.
And the reference range.
The reference range is typically around 17.4 to 50.9 milliabsorbance units per milliliter. Elevated levels tell you the body is struggling to carboxylate its factors, even if the PT is perfectly normal.
You can also just measure the serum level of phylloquinone, right?
You can, yes. A level less than 0.15 micrograms per liter indicates deficiency. But again, PIVKA2 is often more physiologically relevant because it shows you the downstream effect.
We have covered the 4 vitamins in detail. Now let's pull it all together and talk about who is most at risk. It seems like malabsorption is the common thread here.
It's the primary driver. If the gut works properly, these deficiencies are, for the most part, rare. But in the hospital, we see a lot of, well, broken guts.
Cholestatic liver disease is a big one.
Huge. Impaired bile salt secretion prevents the formation of those micelles we talked about at the very beginning.
And without cells.
You cannot absorb long-chain fatty acids or any of the fat-soluble vitamins. This applies to conditions like primary biliary cholangitis, primary sclerosing cholangitis, and biliary atresia in kids.
And what about chronic pancreatitis?
The exocrine insufficiency is progressive and often insidious. About 20% of patients will develop it at 5 years, but that number jumps to around 70% at 20 years. These patients need enzyme replacement, but they also need vigilant monitoring for vitamins A, D, E, and K.
Inflammatory bowel disease is another classic category.
Absolutely. Crohn's disease, specifically when it involves the terminal ileum where absorption happens or after extensive resection, is a major risk. And celiac disease, too, due to the mucosal damage.
We are also seeing many more bariatric surgery patients in our hospitals.
We are. The anatomic changes in procedures like the Roux-en-Y gastric bypass literally bypass the primary absorption sites in the duodenum and proximal jejunum. These patients require lifelong, high-dose surveillance and supplementation.
There are also some rare genetic disorders we should at least keep in the back of our minds.
Yes, there are. Abetalipoproteinemia is one. In this condition, patients cannot make chylomicrons.
So they can't package and transport fats.
Exactly. So they present with severe deficiencies of vitamins A and E. Then there's a condition called ataxia with vitamin E deficiency, which is caused by a deficiency in a specific protein, alpha-TTP.
And what does it look like?
They look clinically identical to Friedreich's ataxia, but the key difference is they are treatable with high-dose vitamin E. It's a diagnosis you can't afford to miss.
Finally, let's touch on drug interactions. We mentioned the competitive absorption between the vitamins themselves, but what about medications?
A few key ones to remember. Orlistat is a lipase inhibitor used for weight loss. It directly blocks fat absorption, so by definition, it blocks fat-soluble vitamin absorption.
Makes sense.
Cholestyramine is a bile acid sequestrant. It binds up the bile salts needed for micelle formation and absorption.
And you mentioned one more.
Broad-spectrum antibiotics.
Antibiotics, how do they play a role?
It's an important one. A significant portion of our body's vitamin K comes from bacterial production in the gut. If you sterilize the gut with long-term broad-spectrum antibiotics, you remove that source.
And if the patient also has poor oral intake from being sick,
they can become profoundly vitamin K deficient surprisingly quickly. We see this all the time in the ICU.
So pulling all this together, what does this all mean for our daily practice?
I think it means we need to move from a reactive stance to a much more proactive one. We really shouldn't wait for the patient to complain of night blindness, or worse, to start bleeding.
So in these high-risk populations, the cholestasis, the pancreatitis, the post-bariatric surgery patients, we need to be screening.
We need to be screening. And when we screen, we need to use the right tools for the job.
Exactly. Don't just trust a normal PT for vitamin K status. Consider looking at PIVKA3 if you're suspicious.
And don't trust a normal vitamin E level in a cholestatic patient. You have to calculate the lipid ratio.
And remember the RBP to transthyretin ratio for vitamin A in your acutely ill, inflamed patients.
These are the nuances that make a difference.
And we also need to be mindful of how we supplement. Spacing out doses might actually improve absorption because of those competitive transporters we started with.
A simple intervention that could have a real impact. And, of course, be vigilant for toxicity, especially with vitamin A and D. We have to remember that more is not always better.
This has been a true deep dive. I mean, we've gone from the molecular level of SRBI transporters all the way to the bedside assessment of ataxia and bleeding.
It really highlights that vitamins are not just, optional supplements from the health food store. They are critical biological cofactors with an incredibly complex physiology.
Before we wrap up, I want to leave our listeners with a provocative thought to mull over, something to think about on their next shift.
Okay.
Consider the future of vitamin K research. We focused mostly on coagulation, but this emerging role of vitamin K2, the mini bones and vascular health, is just fascinating.
It is.
So the question is, are we underdosing our patients for long-term preventative health when it comes to things like vascular calcification and cardiovascular disease?
And you could ask the exact same question for vitamin D. The debate about optimal levels for extraskeletal benefits is far from settled. Are we simply preventing rickets, but allowing other chronic diseases to simmer by accepting adequate rather than optimal levels?
Important questions that might completely reshape our guidelines in the next decade. Thank you for joining us on this deep dive into the fat-soluble vitamins.
It was a real pleasure. Keep questioning the physiology.
That's it for this episode of Hospital Medicine Unplugged. We will see you next time.